Today, I would like to discuss with you the topic hypoglycemia in cardiovascular medicine, why worry? So the topics to be discussed are the following. How common is severe hypoglycemia in diabetic patients? Which diabetic patients are at increased risk for the development of severe hypoglycemia? How are the associations of severe hypoglycemia with cardiovascular events, all-cause mortality and cardiovascular mortality? And finally, we would like to discuss the strategies to avoid severe hypoglycemia in the treatment of diabetic patients. This is a very recent study from Schlot. She analyzed the risk of severe hypoglycemia in sulfonylurea-treated patients from diabetes centers in Germany and Austria. The questions were, how big is the problem? Which patients are at risk? So the rate of severe hypoglycemia was investigated in about 30,000 patients with type 2 diabetes treated with sulfonylurea in diabetes centers. The median age was 70 years and diabetes duration was 8 years. As you can see, a severe hypoglycemia was reported in about 3% of the patients during the last year of sulfonylurea treatment. And the adjusted event rate was about 4, for coma about 2, and for hospitalization about 1.6. It is important to add that patients with severe hypoglycemia were older and had longer duration of diabetes compared with patients without severe hypoglycemia. The event rates for severe hypoglycemia were related to the type of treatment. The highest risks were seen in patients using sulfonylurea together with insulin, so the risk ratio was 6.7, whereas the risk was much lower when sulfonylureas were used alone or together with other oral agents. Risk for severe hypoglycemia was very high in patients with impaired renal function. As you can see, the rate was 7.7 in patients presenting with an EHR lower than 30 milliliter per minute. So the authors concluded high risk of severe hypoglycemia was associated with lack of diabetes education, older age, decreased renal function, but also with lower BMI, suggesting that sulfonylurea treatment in those patients should be considered with caution. The highest risk for severe hypoglycemia was seen in patients who used combination of insulin with sulfonylurea and was highest in patients with impaired renal function. So this is a very new publication which came out in the December issue of Diabetes Care 2017. These are data from the ARIC study performed in 1,200 patients. And during the follow-up of 15 years, there were 185 severe hypoglycemic events. And the important risk factors after multivariable adjustment are summarized here. So age was a very important factor, increasing the risk by 24% for 5 years. Black race, diabetes medications, insulin versus non-insulin. The hazard ratio was 3. Oral medications versus no medications. Poor glycemic control was also a predictor, macroalbuminuria, as well as poor cognitive function. In conclusion, these factors should be considered in hypoglycemia risk assessment when individualizing diabetes care for older patients. This was also published in Diabetes Care in December issue. It's coming also from the ARIC study. And you can see here, after severe hypoglycemia, the 3-year cumulative incidence of coronary heart disease was 10% and of mortality was 28%. After adjustment, severe hypoglycemia was associated with coronary heart disease, all-cause mortality, cardiovascular mortality, and cancer mortality. Hypoglycemia, however, was not associated with stroke, heart failure, atrial fibrillation, or non-cardiovascular, non-cancer deaths. This is a study from Goto, published in Japanese patients with severe hypoglycemia. And you can see, very similar as in the US, age is an important factor, diabetes duration is an important factor, and insulin treatment. So the risk is 7-fold increased in patients using insulin, whereas the risk is decreased in patients who received metformin, pioglitazone, or GLP-1 receptor agonist. In a multivariate Hazard model, severe hypoglycemia was strongly and positively associated with the risk of cardiovascular disease. As you can see, the Hazard ratio was 3.4. And the risk was even higher in the propensity score matched cohort, so the risk ratio increased to 7.3. So let's come back to the old studies. In the Accord Advance on Veteran study, intensive glucose control was associated with a significant increase of severe hypoglycemic events. And these severe hypoglycemic events were related to the use of insulin. As you can see, in Advance, the risk for severe hypoglycemia much less, since they used insulin only in 40% at the end of the study. Whereas in the Accord and Veteran study, 77% and 89% have used insulin. And also the type of sulfonylureas were different, and it's believed that glycoside is associated with a much lower risk of hypoglycemia versus glimepiride. And the outcome of severe hypoglycemia was really alarming. In the Advanced study, patients with severe hypoglycemia had a fourfold increased risk for all-cause death and cardiovascular death. And also in the Veteran study, severe hypoglycemia was a very strong predictor for cardiovascular death. More recent studies showed that there's an increased mortality after severe hypoglycemia in the large retrospective study from the Mayo Clinic in Rochester. You see here the number of patients, 1,000 patients, and about 7% reported severe hypoglycemia. And the mean age was about 60 years, very typical for type 2 patients. HbA1c was not high, it was 7.3%. And as you can see, after 5 years of follow-up, patients who reported severe hypoglycemia had a 3.4-fold higher mortality compared with those who reported mild or no hypoglycemia. And here you have the results. So as you can see, severe hypoglycemia increased the mortality enormously. These are data from Tahoe showing the cumulative incidence of cardiovascular events in veteran patients with or without hypoglycemia. And as you can see, these are the data of the control group. And in the patients presenting with hypoglycemia, there was an increased rate, as you can see here. And this was the case after a short period, after 2 years, as well as after 3 years. Some years ago, I criticized that the severe hypoglycemia was downplayed in the Origin study at the time of the presentation. And at the AISD lecture, I said severe hypoglycemia must be dangerous, despite it was said probably it was not a problem at the beginning. But later on, they showed very clearly that severe hypoglycemia was significantly associated with increased mortality, cardiovascular death, and arrhythmic death in the Origin trial. But interesting enough, the risk was even higher in the control group when the patients received metformin and sulfonylurea. So the outcome of the Origin study would have been totally different when in the control group other drugs were used, for example, metformin and SGLT2 inhibitors, not inducing hypoglycemia at all. So these are data from Kamlesh Kunti. These are observational data from United Kingdom. And as you can see in type 1 as well as in type 2 diabetic patients, there's an increased risk for cardiovascular events and all-cause mortality in patients with and without a history of cardiovascular disease. These are data published in Neurology. What they did is also quite interesting. They analyzed the risk of stroke, coronary heart disease, congestive heart failure, and mortality in patients presenting with chronic kidney disease who had more than 2 severe hypoglycemic events. As you can see, all the parameters, stroke, coronary heart disease, congestive heart failure, mortality increased enormously in these patients. So let's come now to very new studies. So very recently in diabetology, Thomas Bieber published data from the DEVOTE study. As you know, in the DEVOTE study, patients with established cardiovascular disease, in 85%, were randomized to either insulin degludec and insulin glargine. And the follow-up was 2 years. As you can see, 5% of the patients died. And as expected, severe hypoglycemia occurred less in the deglutide group compared to the glargine group, 4.9% versus 8.2%. However, the risk of all-cause mortality and cardiovascular death was significantly higher in patients who had versus those who had not severe hypoglycemia. So the hazard ratio was 2.51 for all-cause mortality and 2.1 for cardiovascular. So the risk was doubled. So the risk of death, interestingly enough, was highest in the short term after severe hypoglycemia. You see here the data for cardiovascular death, and in this slide, you see the data for all-cause mortality. So all-cause mortality was highly significantly increased in the patients presenting with severe hypoglycemia, irrespective whether insulin deglutide or insulin glargine was used. And as you can see, the risk was highest after 15 days, 4.2, but it declined over the time a little bit, but remained always statistically significantly increased risk. So coming almost to the end, what are the pathophysiological cardiovascular consequences of hypoglycemia? There are a number of papers in the literature. We also made a review together with Simon Heller and Brian Freer. And as you can see, hypoglycemia induces abnormalities in the coagulation, hyperactivation of platelets, you have activation of neutrophils and factor VIII, but you have also some endothelial dysfunction, vasodilatation, and altogether you have also inflammation, and this might explain, together with the sympathoadrenal response, the increased epinephrine and the arrhythmia, the problem why hypoglycemia is so dangerous for patients with established cardiovascular disease. So coming to the critical question, is hypoglycemia and cardiovascular risk of mortality causal or association? In some cases, a direct causal link between severe hypoglycemia and acute death seems very likely in the so-called dead in bed syndrome. The twofold increased risk of sudden death in patients with type 2 diabetes after myocardial infarction could also be linked to severe hypoglycemia. Diabetic patients with severe hypoglycemia have an increased vulnerability of all-cause and cardiovascular mortality, as well as for severe vascular complications, and irrespective whether the increased cardiovascular risk and mortality in patients with severe hypoglycemia is causal or only associated, preventive strategies to avoid severe hypoglycemia are mandatory. There is increasing evidence that hypoglycemia has to be avoided in risk situations of patients with type 2 diabetes, such as long duration of diabetes, presence of macrovascular complications, acute myocardial infarction, stroke, impaired renal function, coronary revascularization, intensive care unit, and finally, unawareness to hypoglycemia and high age with hypovigilance. So recently we made a review, the treatment recommendations for older patients. The paper will come out in the Hepatology very soon. And we state the heterogeneity of older patients must be considered, and there is a need to individualize all therapeutic strategies based on specific factors that predict benefits and risk, including the functional and cognitive status and the burden of comorbidities. Glucose-dependent drugs that do not induce hypoglycemia should be preferred because elderly patients with impaired kidney function are especially vulnerable for these adverse events. Fortunately, today, we have a number of glucose-lowering drugs not associated with hypoglycemia, not only metformin and DPP-4 inhibitors, but also pioglitazone, GLP-1 receptor agonists, acapose, and SGLT2 inhibitors. On the right side, you have the three classes of drugs inducing hypoglycemia. So coming to the summary, severe hypoglycemia is a dangerous complication of aggressive glucose-lowering therapies. The risk is particularly high when insulin and sulfonylureas are used in combination in patients vulnerable for this severe event, such as older patients with impaired renal function. All cardiovascular events, cardiovascular death, and all-cause mortality are significantly associated with severe hypoglycemia. In patients at increased risk for severe hypoglycemia, glucose-lowering drugs should be preferred, not inducing hypoglycemia. Many thanks for your attention.